Bismillahirrahmanirrahim. Functions of the glucocorticoids are discussed in this video. Adrenalectomy leads to the loss of mineral corticoids as well as the glucocorticoids. While mineral corticoids, they are crucial for the immediate survival, that is the fluid and electrolyte balance. The glucocorticoids, mainly cortisol, are essential for maintaining long-term health and life, regulating protein, carbohydrate, and fat metabolism, and enabling the body to cope with the stress. The consequences of glucocorticoid deficiencies are that without glucocorticoids, there is metabolic system derangement that particularly involve the production of the energy and utilization of the energy or nutrients utilization, and they also are unable to resist stress, both physical and mental stress, and this can be fatal. Minor infections or illness can become life-threatening due to weakened stress and immune response. The primary glucocorticoids are cortisol, that is hydrocortisone, that accounts for about 95% of the glucocorticoid activity, and this is the main hormone that is responsible for the energy metabolism and stress adaptation. The corticosterone, it is small, its contribution is small, but a significant portion of glucocorticoid activity. Cortisol affects the carbohydrate metabolism. How? The cortisol stimulates gluconeogenesis. So what is this gluconeogenesis? This is the formation of glucose from non-carbohydrate sources such as protein and amino acid. There is increased rate of gluconeogenesis about 6 to 10 times by direct action of cortisol on the liver and contracting the insulin's inhibitory effect. So this cortisol, it increases the enzyme production in the liver. So cortisol activates DNA transcription in the liver cell nuclei. This leads to formation of messenger RNA, which promote the synthesis of enzymes that are essential for gluconeogenesis. Then there is mobilization of amino acid from extrahepatic tissue such as muscle. So cortisol mobilizes these amino acid from extrahepatic tissue such as muscle, and these amino acid enter the bloodstream and used by liver to produce the glucose. And the third effect that we have already discussed is the insulin antagonization. Insulin stimulates the glycogen synthesis and inhibits gluconeogenesis. So cortisol suppresses insulin's inhibitory effect, thereby enhance the glucose production. There is additional effect that increased glycogen storage in the liver due to cortisol action that enhances glycolytic response of other hormones like epinephrine and glucagon, allowing quick glucose release during fasting or stress. The cortisol causes decreased glucose utilization by the cell. This precise mechanism of this effect is not known, but it is suggested that it is due to decreased translocation of GLUT4 to the cell membrane that produces insulin resistance, and then the glucose is less utilized by most of the cells. Glucocorticoids may also depress the expression and phosphorylation of other signaling cascades that influence the glucose utilization directly or indirectly by affecting protein and lipid metabolism. For example, glucocorticoids have been reported to reduce the expression of insulin receptor substrate 1 and phosphatidylinositol 3 kinase. Both are involved in mediating the action of insulin as well as oxidation of nicotinamide adenine dinucleotide NADH to form NAD. Because this NADH must be oxidized to allow glycolysis, this effect could also contribute to diminished utilization of the glucose by the cells. So elevated blood glucose concentration is achieved by two mechanisms by the effect of cortisol. One is the uh, gluconeogenesis and reduced glucose utilization by the cells. The increased gluconeogenesis is due to stimulation by the cortisol of the liver, and liver produce more glucose from amino acid and other substrates, and there is decreased glucose utilization because cortisol causes insulin resistance by reducing glucose transporter activity. GLUT4 are inhibited. So then decreasing insulin signaling and skeletal muscle and adipose tissue, and increasing fatty acid level, which further impair insulin secretion. So ultimately there is a rise in blood glucose level. So there is increase in blood glucose that may increase 50% or more above normal. This triggers excessive insulin secretion, but this secretion is ineffective due to resistance of the tissue. This condition mimics diabetes mellitus but arises from excessive cortisol rather than insufficient insulin. So this is also termed as adrenal diabetes. So this adrenal diabetes is caused by glucocorticoid overproduction, not by pancreatic beta cell failure. So this increased blood glucose level is similar to the patients that present with increased growth hormone production, and the level is more than 50% above normal. So this is the mechanism of adrenal diabetes. So insulin administration is not going to uh, correct this defect. So reduction in the cellular protein is one of the effect of cortisol. Cortisol causes decreased protein synthesis as well as increase the protein catabolism. There is decreased amino acid transport into the extrahepatic tissue, and there is also decreased RNA formation that leads to decrease in protein formation in muscle and lymphoid tissue, and all the body tissues have got decreased protein stores except liver. Here the plasma proteins and other proteins are formed that support glucose production. So this condition, the increased cortisol, is associated with the weak muscle. There is a weakening of the muscle. In severe cases, it is so much that person may struggle to stand from a sitting position, and cortisol also results in weak immunity because the protein content in the immune tissues is decreased. Excess cortisol conditions such as Cushing syndrome leads to muscle wasting and weakness, and also there is increased susceptibility to infection due to impaired immune system. So, uh, while the cortisol it reduces protein in most tissues, it increases protein content in the liver and boosts plasma protein production. There is enhancement of amino acid transport. So cortisol promotes the movement of amino acid into the liver cell, unlike in the muscle or other tissue where amino acid uptake is reduced. And also there is activation of liver enzyme. So there this cortisol increases the activity of enzymes involved in protein synthesis within the liver, and there is increased plasma protein formation such as albumin and clotting factor, and so their concentration is increased in the blood. Or also the plasma protein and liver protein that are involved in the formation of the glucose pathway, they are also increased. So most tissue loses protein due to reduced synthesis and increased breakdown, but the liver uses the mobilized amino acid from muscle and other tissue to make new protein for metabolism, enzyme production, and transport the plasma protein, and for immune response. This mechanism support gluconeogenesis and maintain blood protein levels, which are vital during stress, fasting, or infection. So the cortisol causes increased blood amino acid, decreased transport of amino acid into extrahepatic cells, and enhanced transport of the amino acid into hepatic cells. How this happens that amino acid decreases the amino acid transport into the muscle cells and other extrahepatic tissue, and so there will be decrease intracellular amino acid concentration. So as the uptake is decreased, concentration is decreased, so the protein synthesis is also decreased. Simultaneously there is continued protein catabolism that causes the increased release of these amino acids, so plasma amino acid concentration is also increased. These amino acids are mobilized from non-hepatic tissues, and also there is increased transport of amino acid to the liver cell. In the liver, these amino acids then they are responsible for increased rate of deamination of amino acid. This means the removal of amino group from the amino acid, increased protein synthesis in the liver, increased formation of the plasma protein, and increased gluconeogenesis. So the net result is the peripheral tissue loses protein that lead to muscle wasting in prolonged cortisol excess, and liver function and glucose production are enhanced, and these increased amino acid they act as a fuel for the liver during stress or fasting. So imagine the muscle as a warehouse being emptied of protein crates which are loaded onto the trucks and sent to the liver factory. In the factory, the crates are repackaged into plasma protein and converted into energy bricks that are glucose. Like protein, cortisol is also responsible for mobilization of the fatty acid. Cortisol has direct effect on oxidation of the fatty acid in the cells. So there is increased oxidation that results in mobilization of fatty acids from adipose tissue. So there will be increased concentration of these free fatty acids in the plasma that are used as energy source. So this leads to long-term conservation of the body glucose and glycogen. The exact mechanism of this is unknown, but one is proposed that there is a decreased glucose transport to the cell that lead to the absence of alpha glycerophosphate. This alpha glycerophosphate is a derivative of the glucose. So when it is deficient, uh, there will be mobilization of fatty acid from the adipose tissue because this alpha glycerophosphate was required for the deposition and maintenance of triglyceride in the fatty tissue. By promoting the fat utilization, cortisol spares glucose and conserves glycogen stores for times when quick energy is needed, for example, emergency or high activity. The excess cortisol lead to an unusual pattern of fat deposition, particularly in the chest. There is buffalo-like torso or face that is called as a rounded moon face, and the neck and upper back are they produce appearance like buffalo hump. So the cortisol mobilizes fatty acid from adipose tissue. It also increases appetite and food intake that lead to more fat generation, promotes fat storage in certain region of the body more rapidly than fat is oxidized for energy. So there is imbalance between fat mobilization and fat deposition that causes the accumulation of fat in specific areas despite overall catabolic effect. So the patient with Cushing syndrome or excessive cortisol often shows moon-like face, buffalo hump, and central obesity, while limb may appear thinner due to muscle protein breakdown. Almost all form of physical or mental stress causes increased secretion of the ACTH by the anterior pituitary. ACTH stimulates the adrenal cortex to secrete the large amount of the cortisol within minutes, and 4 to 20 minutes are usually required for this action. And any stress such as trauma, infection, intense heat, cold, injection of norepinephrine and other sympathomimetic drugs, surgery, subcutaneous injection of necrotizing substance, restraining of animal so it cannot move, and debilitating diseases. All these are associated with the stimulation of the uh, anterior pituitary or ACTH secretion from the anterior pituitary. So there is rapid mobilization of the labile amino acid from the protein breakdown and fatty acid from adipose tissue and glucose via gluconeogenesis. So damaged tissue can use mobilized amino acid to synthesize essential protein and enzyme, and mobilized amino acid may help produce purines and pyrimidines that are the DNA, RNA building blocks, creatine phosphate that is energy reservoir for the cell. So cortisol mobilizes readily available or labile protein first. Structural protein like muscle contractile protein and neuronal protein are spared unless other stores are depleted. This graph illustrates the rapid reaction of the adrenal cortex of a rat to stress caused by fracture of a tibia and fibula at time 0. Here, this 0 time, and in rats, corticosteroids serve as the primary glucocorticoid hormone instead of cortisol. So in the upper panel over here, the adrenal corticosterone concentration in microgram per gram is given. Initial phase is 0 to 2 minutes. The corticosterone concentration in the adrenal gland remains relatively stable, fluctuating slightly between 5 to 10 microgram. Within 2 to 6 minutes, the stress response, it begins after 4 to 5 minutes, after the 4 to 5 minutes of the stress. And this corticosterone concentration peaks around 8 to 10 minutes, reaching values near 40 to 45 microgram per gram. So there is a plateau or fluctuation after the peak because it fluctuates between 25 to 35 microgram per gram for the remainder of the 30 minutes observation. Here there is decrease, and then in the lower panel there is initial phase that is it is first showing the corticosterone in microgram per 100 milligram. Initial phase is 0 to 3 minutes where this 0 to 3 minutes, that is initial, and here the corticosterone level remains low around 5 to 10 microgram per 100 ml, and then within 5 to 10 minutes there is rapid increase, dramatic increase following the stress that reaches to peak for about 20 to 30 minutes, and it steadily climbs and approaches 55 to 50 microgram per 100 ml by the 30 minutes. So this is showing how stress triggers a fast and robust activation of the adrenal cortex, leading to a significant increase in corticosterone secretion in both the adrenal gland and in the plasma. The adrenal corticosteroid level increases first, followed by delayed but sharp rise in the plasma corticosterone, indicating secretion into the bloodstream. This response represents the body's acute stress reaction mediated by ACTH release and activation of the hypothalamic pituitary adrenal axis. Cortisol plays a major role in controlling and suppressing the inflammation, uh, especially when present in high concentration. The key stages of inflammation are the chemical release, the damaged tissue cell release, histamine, bradykinin, prostaglandin, leukotriene, and proteolytic enzymes initiating the process of inflammation. Then there is increased blood flow. These chemical mediators cause redness or erythema by increasing local blood flow. Then there is plasma leakage. Increased capillary permeability leads to leakage of plasma, followed by clotting resulting in non-pitting edema. And then there is infiltration by the leukocyte. The WBCs migrate into the affected area to combat the infection and remove the debris. Then there is fibrous tissue growth. Over time, the fibrous tissue growth into the area to support the healing. Then what are the effects of the cholesterol on inflammation? The cortisol has got two major anti-inflammatory action. First is the prevention of early inflammation. It blocks the release of inflammatory chemicals and prevent increased blood flow, plasma leakage, and leukocyte infiltration. And there is resolution of existing inflammation. If inflammation is already present, cortisol promotes rapid healing, reducing the swelling, redness, and immune activity. Cortisol acts as an powerful anti-inflammatory agent by targeting multiple steps in the inflammatory process. It stabilizes the lysosomal membrane. The lysosomes are bags of proteolytic enzymes. These enzymes, when released, damage the tissue and trigger the inflammation. Cortisol stabilizes the lysosomal membrane and make them less likely to rupture and release enzyme. Then, as these proteolytic enzymes are decreased, cortisol also reduces the permeability of the capillary, preventing excessive plasma leakage and tissue swelling. Then it also reduces white blood cell migration and phagocytosis. So there is less formation of prostaglandin and leukotriene that are the key mediators of the attraction of the white blood cells to inflamed area. As a result, fewer immune cells infiltrate the tissue, so inflammation is decreased. It also suppresses the immune system by inhibiting the production of T lymphocyte, leading to the fewer immune response in the affected area. This reduces antibody production and tissue damage caused by an active immune system. It also lowers fever, that is the antipyretic effect of this cortisol. It decreases interleukin 1, and this interleukin 1 released from the WBCs, and normally it is responsible for signaling hypothalamus to increase the body temperature, but reducing the interleukin 1 reduces the temperature and prevent excessive vasodilation. So overall, cortisol globally suppresses inflammation by acting on enzymes, blood vessel, immune cells, and temperature control mechanisms. Cortisol not only prevent inflammation but also resolve it once the inflammatory process is already established. Its effect extend beyond blocking inflammatory signal. It aid in healing and recovery by supporting cellular repair and energy availability. So cortisol inhibits the release of pro-inflammatory chemical such as prostaglandin, leukotriene, and cytokines. And as we have seen earlier, it mobilizes amino acids from tissue and make them available for protein synthesis needed for repairing damaged tissue, enzyme production, and it also stimulates gluconeogenesis. For that is the production of the glucose, and release fatty acid, ensuring steady energy supply for the healing cell. It also removes inflammatory byproduct. It inactivates or eliminates leftover inflammatory products and speeding up the tissue recovery. It has got some therapeutic importance also in disease like in disease like rheumatoid arthritis, rheumatic fever, and glomerulonephritis, excessive inflammation can damage tissue. So cortisol or glucocorticoid drugs quickly suppress this damage, and this suppression occurs often within 24 hours of administration. So cortisol does not cure the underlying disease, but by suppressing the harmful inflammation, it prevents tissue damage and buys critical time for recovery. Cortisol plays a crucial role in blocking the or controlling the harmful effect of severe allergic reactions such as anaphylaxis by targeting the inflammation that accompanies these reactions. So there is no direct effect of these cortisol or antigen antibody reaction. It is not going to interfere with the primary antigen antibody binding that triggers an allergic reaction. It blocks the harmful inflammatory response. The secondary inflammatory cascade, such as the release of histamine, prostaglandin, and leukotrienes that follow the allergic reaction, is suppressed by cortisol. This prevents swelling, vascular leakage, and shock that can be life-threatening during severe allergies. In conditions like anaphylaxis, uh, shock or anaphylactic shock, the cortisol reduces inflammation-induced swelling in airways and blood vessel, preventing fatal outcome. So cortisol and synthetic glucocorticoids are key drugs in emergency treatment for severe allergic reaction alongside epinephrine. Cortisol in both the natural and high synthetic doses has significant effect on blood cell count and immune function. These effects are crucial for both physiologic and therapeutic, but can become harmful if cortisol level is excessively high. So there is reduction in white blood cells, decrease eosinophils, and decrease lymphocytes in the blood within minutes to hours after the cortisol injection. So lymphopenia and eosinophilia are the terms that are often used as diagnostic marker for cortisol overproduction or Cushing syndrome. Then there is immunosuppression by atrophy of the lymphoid tissue, such as thymus, spleen, or lymph node that occur with high dose of cortisol. So this will lead to decreased T cell and antibody production that lead to weakened immune response and increased risk of severe infection such as fulminating tuberculosis, which may be lethal despite being manageable under normal immunity. And there is also uh, these can be also used, these cortisol can also be used as a prevention of transplant rejection. So they prove beneficial in preventing organ rejection in heart, kidney, and liver transplantation. There is effect on the RBCs also, but it is through unknown mechanism. There is increase RBC count. So cortisol deficiency will lead to anemia or reduced RBC production. So this picture is summarizing the effects by glucocorticoid. It is responsible for gluconeogenesis. It decreases the utilization of the glucose and elevate the glucose level. It also increases the mobilization of amino acid from the peripheral tissue, and it also causes the breakdown of the protein in the peripheral tissue. So increase catabolism of the protein and uh, sparing the liver where there is increase formation of proteins for various synthetic mechanism of the glucose pathway, and various plasma protein and anticoagulants are produced. Then it has got also effect on the fat metabolism. The fatty acids are mobilized and cause fat redistribution. Then it increases resistance to the stress and provide energy substance during the active stress. Then it also affects the inflammatory system, so inflammation is suppressed and tissue uh, healing is promoted also by this. And then it can cause the suppression of the immune response by causing lymphopenia and eosinophilia. On the other hand, it causes the production of RBC, increased production of the RBCs. Thank you for watching this video. If you have any query, please write in the comment box.